This learning resource is designed to help health professionals with the development of skills around breaking and sharing bad news for clients and or families. It's been supported by the Australian Department of Health and the Western Australian Clinical Training Network. So the task of breaking bad news is not an easy one, but if we don't do it well, do it badly, the patients or the family members we've been interacting with may never forgive us. If we do it well, on the other hand, they may never forget us. The outcomes I'm hoping you'll be able to achieve by completing this learning resource include being able to define bad news or clarify your current definition of bad news, being able to recognise the challenges that exist around being able to share bad news and the supports that you might be able to put in place to help you with this, being able to understand how health professionals should break bad news most effectively and empathetically. There are some frameworks and protocols in the literature that you can use to help you in this task, and one of these is the SPIKES protocol we're going to be looking at and using a little today. And we'll be using a set of videos within this learning resource to operationalise this particular protocol, reflect upon their use, and hopefully use that for you in the future to apply in your own practice. Is breaking bad news, sharing bad news, a skill? Is it not? Hopefully, by acquiring the skill and putting it into practice, it will become an art for you in the future. It's not a pleasant task, as I've already alluded, so you need to develop a skill and the communication strategies around it to make it a little easier for you every time you do it, therefore easier for the people who are receiving your news. It's just as hard for the person delivering the news as it is for the person receiving the news, and if we do it the wrong way or at the wrong time, then the reception of this particular news can be even worse than it is or than it may be. So what is bad news? One definition here is that information that's going to negatively impact upon the individual or their expectations about their future could be called bad news. Anything that is going to have an impact upon how you perceive the future, your future health-wise, your loved ones or your family's future, could be perceived to be bad news. But as we suggest here on this slide, your bad news may not necessarily be my bad news. Your experiences, your values, your expectations will all influence what you see bad news to be. And we, as the health professionals delivering bad news, must keep that in mind and accept that because we're all unique, our values, our views of bad news are going to differ from person to person, and therefore everybody's reactions to the news that we give them may well differ from person to person. And what is bad news will be different from one end of the continuum to the other. We will possibly have to give bad news about a change in diagnosis, all the way up to possibly having to give bad news to a family or a patient about their prognosis, which may be fatality. There are indeed challenges for us and for the people we're talking to when giving bad news. People, yourself included, may not have had training as yet or experience. There may not be protocols and guidelines available to you, and you may not yet have had a role model, someone to work with, to model yourself on when giving bad news. And in the act of giving, or the interaction of giving bad news, you may well, and I would perhaps expect that, you might be concerned for the impact of the news upon the family and how they're going to react when you talk to them. And you yourself may be concerned for your own responses to how you're going to feel about giving this bad news and how you're going to react to the patient or the family's responses if they show anger or fear or denial. How will you manage that? All of these are challenges that you have to keep in mind and think of strategies to manage when you're going to effectively deliver bad news. So there needs to be some sort of support in place, or you need to be able to keep this in mind, to put this in place for yourself if you're going to be in the position to deliver bad news. For the family and or patient, it's a good idea to be including them in conversations and planning leading up to be delivering bad news. Including them as care partners is a good idea, and this particularly pertains to patients in hospital and their family, or patients who are in your care long term in the community. If it's the delivery of bad news to people you're meeting for the very first time, then these points are not applicable, of course. But if it's people in your care who you are likely to know on a long-term basis, then including them in conversations that are likely to give them background and lead them up to the information you're going to give them is going to make sharing of the bad news a little easier for both of you. Health professionals can be supported in their skill, in their task, by training and practicing in both in good communication skills and in specific communication skills around the delivery of bad news, and hopefully that's what this learning resource will help you with. And then you need to look into strategies and develop strategies that will help you cope with the emotion and the distress, both for the patient and their families and perhaps yourself, that surround these sorts of situations and issues. And part of that process might be having someone there to support the family, particularly if the person that you're going to have to talk to is going to be on their own, and then later on having the right sort of support mechanisms in place to support you, the healthcare professionals, after you've had to deliver bad news. So some sort of debriefing scenarios might be useful. That might be your family, that might be a friend, or it might be a formal counselling, pastoral care scenario in the healthcare setting. Now, bad news is best shared when you've got strong communication techniques, strong communication strategies, and something that you might like to look up and follow up is therapeutic communication. I won't go into this in great depth, but I touch on it here because the research is showing that healthcare professionals with good therapeutic communication strategies are recognised easily by both their peers and particularly by their patients. And it's linked in the research with patient safety these days. So therapeutic communication is characterised, as we say on this slide, by people demonstrating understanding and empathy to each other, so us to our peers and us to our patients, by being able to show that we are there and available, and by being genuine in our interactions and our communications and demonstrating self-awareness. So to demonstrate that in a little bit more depth, as a health professional, if we have authenticity or demonstrate authenticity and genuineness in our interactions with people, if we are able to be empathetic and not to confuse that with sympathetic in our interactions, and be self-aware as a person and a healthcare professional, have those skills, and you can unite those with validation when you're talking to people, and particularly in the scenario of giving bad news and people respond to you either negatively or they start to show strong emotions. Validation is talking about recognising that those emotions that they are expressing are important for them, are right for them at that time. A person may be expressing emotions that seem completely off centre, with respect to your usual emotions or what you would have expected for that person, but they're right for that person at that time in that context. And so you would say something along the lines of, I can see that you're feeling X. Not so much I understand, but this must be very, very difficult for you at this time. What can we do for you? Something along those lines. So I can see that you're feeling this particular emotion or whatever, rather than I understand, or I completely understand what you feel, because none of us can completely understand what somebody else feels. You need to be mindful, and developing a skill around mindfulness. This is something that some of you may well know what I'm talking about. It's about paying attention on purpose to what's happening at the moment and trying to be non-judgmental about the people that you're interacting with or working with, and looking at what's happening at the moment as it unfolds. So being in the moment and trying to work non-judgmentally with the people that you're helping or working with or interacting with, and having a therapeutic presence, if you can, bringing all of yourself, your clinical self, your values, your experiences, into the moment with the people that you're communicating with, to be beneficial for their care. But at the same time, putting your biases and assumptions aside as much as you can. It's an easy thing to say, but a hard thing to do. And hold those beliefs and assumptions aside, knowing that they can influence how we respond to people. So no, it's not possible to do that completely, but be aware. This is being mindful again, being aware that these assumptions and biases affect our decisions, affect the way that we respond to people. So if you see that happening, try and hold it back so that you don't upset people too much, or you don't influence decisions that people make. Allow them to make their own decisions. Again, I've already mentioned this with mindfulness. You should try not to be judgmental or influence people's decisions too much, and not make judgmental statements like I completely understand, or make judgments about the way a person is reacting. Allow them to make their own reactions to, have their own reactions to whatever is happening while you're talking to them. If you can do all of that, bring those attributes to an interaction with people. And we're talking about giving bad news at the moment, but this can apply to any sort of interaction you're having with peers and patients and their families in the clinical setting. Then you'll be able to communicate therapeutically and enhance the interaction overall. So in the context of communicating or sharing bad news, this particular model or protocol, the SPIKES protocol, was developed in the oncology setting, but can apply to giving bad news anywhere across the healthcare setting. And it has 6 steps to direct the process. So setting the situation applies to making sure you've got a private area, a place that you can make safe for the communication, and making sure that you've set everything else up. You know the background to the communication that's going to occur. The perception is all about making sure that the person's or the family's perception of what is needed is clear with respect to the interaction. So getting some idea of their understanding of what's going on. And then invitation refers to developing an understanding of how much the people that you're communicating with really want to know. Do they want to have a full download, if you'll pardon the expression, of all the information related to either their own diagnosis or their family members' diagnosis and prognosis and where to from here, or do they just need a brief overview? And then with respect to knowledge, we're talking about how much information do they need, what sort of language should you be using, and how should that be delivered so that the imparting of knowledge, the breaking of bad news, is done in a manageable and gentle manner, shall we say, and in a manner that ensures that the people got the information that they need, and in a manner that they will actually remember and understand. And then E, we're talking about emotions and empathy, and we're talking about recognising and understanding and acknowledging the people's emotions to support them as they do get this bad news. And then in strategy and summary, we're talking about finishing up the interaction safely, appropriately, summarising what we've been talking about, and then organising a strategy to manage the situation from there onwards. So to extend upon that and elaborate upon what I've just been talking, in this, to set up the situation, the interaction, the delivery of the bad news, ideally this should be done somewhere nice and private, where you can ensure that the person or the people you're talking to will be able to talk to you without being interrupted. You generally will know this group of people that you're going to talk to, but sometimes you might be in the position where they've not met you before. In either scenario, you introduce yourself first of all. As you're setting up for this sort of meeting, you need to know who should be present. The people who are going to receive the news should be supported. If it's an individual, some sort of family member should be there. If they don't have family members, then pastoral care or a nurse or staff member of some sort who can provide emotional support should also be there. As I've said, there shouldn't be any interruptions during the meeting. There shouldn't be people walking past in and out of the room that you're going to be doing this in, and some sort of comfort or welcoming space in which the people can sit and relax to a certain extent, of course, during the discussion should be available. Then mention perception on the previous slide. When we're talking about the Spikes protocol, you need to prepare both yourself and the people you're going to be talking to as you work up to talking about the diagnosis or the prognosis. Need to prepare yourself with the patient or the family member's background and how much they're likely to be able to, shall we say, understand, so the level of language that you're going to be using. And you need to also develop an understanding of how much the patient or family member already knows. So what's their understanding of the situation before you go any further? And then how much do they want to know? Do they, how much do they want to know about the bad news that you're going to know? Do they want to know the whole thing? Do they want to know where to from here? That sort of level of questioning. And a good way to do that is to ask the patient or whoever you're talking to talk to you about their level of understanding. How did we get to this situation? So tell me the history until now, and how much more can I tell you? What would you like me to tell you? So invite them to enter into the situation by asking them to tell you their history, and then asking them, what more can I add to that history for you? And then how do you deliver the knowledge, the information, this bad news? If you use clear language, plain language, not full of jargon, that will help. Although, as I said in previous slides, it's a good idea to assess the person's or the family's understanding and perhaps there will be people who would understand that knowledge delivered with jargon and would appreciate a higher level of language. You need to use a positive body language, maintain eye contact, sort of a leaning forward, positive, interested body language. Get to the point quickly, don't waffle, and break up the information you're giving in small chunks. Pause every now and then to give the person time for the information to filter through, shall we say, and for them to ask a question if they want to, or questions, and wait every now and then for a reaction to your news. And should they start to show some sort of emotional response, pause and let that emotional response to flow. And then use this strategy that I've called teach back here to check and to verify that they are understanding what you're telling them. So we talk about reflecting information, getting them to talk back to you, get them to repeat what you said. Teach back is essentially asking them to reflect what you're told and then explaining it in slightly different language to make sure that they do understand what you've told them, and then getting them to repeat that. Do they understand exactly what you've said? So take the time to make sure before you move on to another point that the people that you're trying to assist with this bad news do actually understand what it all means. And towards the end of delivering the bad news, you will have to get to the stage of where to from here. So it's very important that by that time they have actually understood that message. And then you need to deal with their emotions and empathy, and you do really need to prepare yourself early on and for the fact that there will be emotions flowing, anything from fear through anger, sadness, denial and guilt, depending upon the circumstances for which you arrived at this bad news. It might be someone's poor prognosis, it might be someone's new diagnosis. And if it's someone's poor prognosis related to trauma or an accident, then denial and guilt and sadness may be part of the emotional reaction. So you need to be mindful that any one of these emotions may be part of the bad news scenario. And as I said earlier, you need to be prepared for the fact that the people that you speak to may have a completely different reaction to the news that you're delivering from the one that you expected. But also be mindful that their response is completely valid for them and support them in that response. You should try and comfort the family or have somebody there to comfort the family, and also be aware that you as a human being will be responding to this situation. Giving bad news is not nice, and you will be as a human being distressed by the situation that you're in. So not so much suspend your response, but be aware of it. Try not to indulge in it, shall we say, at the time, but have someone that you can talk to later on to debrief, because it is a challenging situation. And then as you move from the bad news to what now, you need to think, is this person or this family ready for moving on from this bad news to planning for the future, as related to the information that you've just given them. So talk about negotiating what next that might be. Is there some sort of support for the problem that they've got? Do they need to make appointments for the follow-up or for future treatment? And answer any questions, ask, have they got any questions, or answer those questions. And again, use the teach-back technique to make sure that they have understood everything that you've been helping them with respect to their bad news. And then follow up, which involves making sure that you've recorded absolutely everything. And when I say absolutely everything, I'm talking about the information that you gave, specifically, the terms that you used, and the strategies for the future, options that were discussed, and the meetings that might have been made for the future, and other people that are going to be caring for this person, possibly following up with them, must be informed about what was done and planned. And if there are any further meetings to be planned or to be organised, then they should be organised while that person is around. And if you've got support to do that, fine. If not, you should do that with them at that particular meeting. And all of this should be documented. And all of us as health professionals know that everything should be documented. So here's a list of what not to do when breaking or sharing bad news, some of which is self-evident, I'm sure. You don't leave people isolated and stressed by breaking bad news over the phone to them. You don't avoid family and patient when bad news needs to be broken. You don't leave them in suspense, which is almost the same thing. You don't lie to patients and families about bad news. And if they don't want to know an aspect of the bad news, then leave it like that. Don't tell them if they don't want to know. And you frame the information in the manner in which makes it as clearest as possible. So you don't use jargon, pardon me. Give information in chunks that make it easiest and clearest, rather than giving excessive information. You don't want to cause confusion. And you don't collude with family versus patient or patient versus family. You give the same information to patient and family so that everybody understands this and talking on the same page, shall we say. And you suspend your values and beliefs. Try not to be judgmental when you're communicating in this particular area. Don't give a definite time span when people say, how long is it before we get this information, or how long am I going to last? If you give a definite time span, it's invariably not going to be correct. Give a range, days, months. Give a definite time span and it's not correct, then faith in that particular healthcare professional is going to waver. And you don't pretend treatment is working if it isn't, for the same reason as previous point. And it's not a good idea to say nothing can be done, although there is debate around that particular topic. Now we have some videos to follow here to put this information that we've been talking about into application. We have 4 videos, 2 of them the how to and how not to, so to speak, around delivering a diagnosis to somebody, and then 2 around how to and how not to deliver a poor prognosis to a family about their loved one. In between each of these, there will be what we call a reflection pane, asking you to reflect upon the previous video, and then after the better version of the scenario, we'll go through how the scenario applied to the spikes protocol. Was it appropriately applied? And then we'll sum everything up.
Good morning, Georgina, Lucas. How are you? Glad you could both come in today. Well, this is indeed a turn up for the books, isn't it?
What's that?
Oh, I'm so sorry. I thought someone had told you. There is indeed something going on in your head. The MRI results showed a lesion on your brainstem. This has probably always been there and was probably always the cause of your fits.
Can anything be done?
Well, surgery or radioablation is a possibility, of course, but Georgina's been pretty fine up till now. The report says the lump is benign. As I say, it's probably been there all your life, Georgina. We'll have to check it every 2 years for the rest of your life. Would you like to have a few days to take this in and then we can have a bit more of a talk? Or you might prefer to see Dr. Brodie instead. I'll get my secretary to make an appointment for you next week, okay? She can give you the film so that you can take them to the appointment as well. All right. See you later.
Okay.
Thanks.
Thanks.
Georgina, Lucas, please take a seat. I'm glad you could both come in today.
Thanks.
Well, your MRI results are back, which is why I'm glad you could both be here. Georgina, can you tell me again what reasons you were given for your seizures as you were growing up?
My parents always told me that I hit my head hard playing with a cousin. This was when I was about 4. And then I had my first fit that night. That the injury caused a scar on my right temporal lobe, and this is the cause of my fits.
Had you had any scans before now?
No, I've had x-rays, lots of EEGs, and I was told that showed I had a focus on my right side.
Right. Well, interestingly, your MRI results tell a different story.
Really?
Yes, the scans have found an area of tissue that shouldn't be there. Here, if I show you these scans, I can show you what we're talking about. So this is a cross-section of your brain towards the middle. Now see here where the area is grey, that's normal or healthy tissue. Then see here where the area is white or whitish with a fluffy edge, that's the abnormal tissue. The radiologists who looked at these films think this is a glioma.
Wait, we're not talking cancer.
I'm afraid so, but there is good news in with the bad here. Now, because this seems to have been here for quite some time, and I'm saying that because I think this seems to have been the cause of your seizures, Georgina, then we can fairly confidently say that either it's not growing or it might have been growing very, very slowly. Now, one of these lumps or lesions can cause problems like nausea, very bad headaches, and changes in your personality. It can also cause the seizures you've been having, although this seems to have been the only problem that you've had. Of course, that's been more than enough for anyone to deal with.
So what can be done about this?
Well, look, it's very important that we keep an eye on this from now on. What I mean is regular MRIs, about every 2 years, so we can check if it's changing size at all. We also need to keep a close eye on you, your health, and if the lesion is affecting you in any way, so changing your seizures at all, or the other things I mentioned, so headaches, nausea and personality. Lucas, we're going to need your help with this as well.
Of course.
Okay. For the moment though, we should also discuss possible treatment.
Yeah, what can be done?
Okay, well, there's a couple of things to consider here. Now, the position of the lesion is a consideration. It'll be easier if I show you on here. So, the lesion's sitting right on top of this structure here. This is a really important structure. It's called the brainstem. It's a little bit too delicate for us to be operating nearby, so surgery is probably not my preferred option. We could also try radiotherapy, but again, that could also affect your brainstem. Look, at the moment, you seem to be doing really well, health and career-wise. It'd be my recommendation that we continue to monitor your situation closely with MRIs every couple of years, regular checkups with me every 2 years, unless you and Lucas start to notice any changes. And then only consider something radical if you really start to be affected by the thing.
And how long do you think this would be?
Look, in the case of this sort of lesion, you may never need any other treatment apart from the treatment for your seizures, Georgina. considering it's probably been there since birth and you're, what, 35 years old now? It's a really strong possibility. Would the two of you like to think about this for a couple of days and maybe come back next week and we can have a bit more of a talk?
Yes.
You can bring in any questions you've come up with. Right, look, I'll get Angela to make an appointment with you now before you go.
Thank you.
Look, if you think of anything in the meantime before then, please feel free to call.
Excellent.
All right.
Thanks a lot.
Otherwise, I'll see you next week, though. Thanks for coming in. All right.
So in this video, the doctor delivering a diagnosis to the woman regarding her brainstem problem. The setting was in a consulting room, nice and private, reduced possibility of interruption by closing the door. He might well have spoken to his secretary and asked her not to pass any phone messages through, but that's only a supposition. There was no evidence of that in the video. He ascertained his patient's perceptions of her background and essentially gave an invitation to ask questions and tell him about her level of interest in her condition by asking her to tell him her history of her condition. The delivery of knowledge as he worked up to the bad news was a fairly high level. He didn't use a lot of jargon, but he certainly didn't drop the level of information down. But when you look at the video overall, you also notice that he says that her career development had been good, so you can assume that her level of knowledge was high enough to understand information given at that level. He paused at times to allow demonstration of emotion, which didn't seem to happen with this person in this video, and certainly summed up well and laid out a plan for the future and organised for meetings and consultations for the future. He made it very clear what was likely to happen in the future, what was going to happen in the future with respect to follow-up care, and if things changed, what was likely to change and how care would change in the future. So overall, that second video did follow this particular model of care. Now, this second set of videos follows the delivery of Prognosis for Grant, who's the husband of Sandra. And these were a couple who had been married for about 12 years, as we say here. They had 2 children. So Grant and Sandra did a great deal of research before deciding to have the surgery to cut his 5th cranial nerve to treat this trigeminal neuralgia. They were a fairly intelligent pair and decided that the benefits outweighed the risks for this. When he was having his surgery, Sandra and her brother and sister waited during his surgery. Post-operatively, they went and saw him, and he was complaining of severe headache and nausea, and I'm sure you're starting to intuit that something was wrong with him. Sandra, on the other hand, was quite pleased. She had been worrying about something like a stroke or not being able to wake up at all post-operatively. So although he was complaining of a great deal of pain, she was quite pleased to see him awake. He was complaining of very severe pain, and she went with her family, went and had a cup of tea, a bit of a rest while he went to the ward. But she got a phone call a couple of hours later saying that he was not doing well. This pain was a concern. He was going to X-ray to have a CT scan, and could they, the family, go and meet the surgeon after his X-ray, where it was explained that he's not bleeding, but he's got a lot of fluid in his skull, and they wanted to take him to theatre to reduce that swelling. It was further explained to her sometime later, indeed 5 hours later, that they put a shunt in to reduce the cerebral edema. Unfortunately, things continued to go wrong for Grant, and on Thursday, a couple of days later, he displayed decorticate posturing, indicating considerable further cerebral deterioration. And we take up the story from there.
Good morning, Sandra.
Hi, Dr. Gill. What's news? Why have you called us in? Has something happened? Do you have something for us? This is Terry, Grant's sister. I brought her in like you suggested. Hi. Who's this?
Sandra, sit down. Would you like a seat too, Terry? Sandra, this is Dr. Short and Dr. Forster. They're colleagues of mine. They're neurophysicians, so they understand the sort of problems Grant seems to be having.
Great, so they'll be able to help.
No, I'm afraid not, Sandra. At this stage, I think we need help to assess what damage has been done to Grant's brain.
Damage? What damage? You never said there was a bleed on the brain.
Correct, but the swelling and fluid that the shunt was put in for may have caused some problems. We're going to wake Grant up this morning. These two doctors will assess his brain function independently for us, and then we can talk about where to from here. Okay?
I'm so sorry, but your husband's failed his tests.
Yeah, your husband failed his exams. I'm sorry, but at this stage, he's brain dead.
Sandra, did the doctors talk to you about Grant's tests? Yes? Good. I don't think there's anything we can really do. You'll probably have to make a decision. You don't have to make the decision right now. Talk amongst yourselves. If you have any questions, let me know. Morning, Sandra. Thanks for coming in. You know Kylie, don't you?
Hello, Sandra.
She's been looking after Grant for the last few days.
Hi, Dr. Gill. Hi, Kylie. How's Grant? I brought Terry, Grant's sister, as you asked.
Hi.
Hi, Terry.
Hi.
Yes, I want to have a talk about how he's doing, but let's find somewhere you're a bit more comfortable and we can have some privacy. Kylie, can we use the meeting room?
Yes, we can.
Okay, walk this way and we'll have a chat about Grant. Just follow me, please.
What's news?
Come and take a seat. Let me introduce my two colleagues, Dr. Forster and Dr. Short. This is Terry, Grant's sister. Hi, Terry. Dr. Forster and Dr. Short are both neurophysicians, so they can help us with some decisions about Grant.
Decisions?
Do you remember when we talked yesterday morning about Grant's condition? We had a talk about the pressure from the edema fluid on his brain and that it might be causing some damage, that the handling of his brain in theatre had irritated it and caused this.
Yes, but you said then that he might get better, but you couldn't promise.
Yes, that's right, Sandra. It's been 3 days now. We tried the resting of his brain and the different things I talked about to try and get rid of the fluid that's causing the problems. But I'm sorry, he's not getting better, and in ways he is worse.
How can you say that?
I'm afraid the signs that I've been able to see indicate that he may be getting worse. I think we need help to assess what damage has been done to Grant's brain.
Damage? What damage? You said there was no bleeding on his brain. And yesterday he was moving his arms.
He hadn't had any more bleeding, Terry. You remember though when we brought Grant back from the theatre the second time? He had to be in there for quite some time while they were trying to put that shunt in. The shunt was put in to try and reduce the swelling and fluid that seems to have happened after his first surgery. I'm sorry to say, but the swelling has continued or not gone down and caused some damage to Grant's brain. The movement you saw in his arms yesterday, I'm sorry to say, is one sign of that damage. If you think back to then, you will have noticed that his movements were stiff and were actually abnormal.
They were stiff, come to think of it.
Yes. These are spasms that show certain areas of Grant's brain have been badly damaged. I'm so sorry, but I think the damage may be so severe that Grant may in fact be brain dead. We will need to undertake some very stringent tests to be certain of this. We have been observing him closely for the last couple of days, as you know, and there are also other signs that suggest this. The other signs that concern me are that overnight we've been reducing the drugs that have been keeping Grant asleep so that he can tolerate the tube connecting him to the ventilator. You will have noticed that he is not coughing this morning. Normally, you or I would cough like mad if we had a tube like that in our throat. So that is another reason we are very concerned about Grant. Dr. Forster and Dr. Short here will do these tests for us so they can give us a very clear idea of how much damage has been done to Grant's brain. They will take a while to do this because there needs to be a time lapse between each set of tests.
Brain dead? What does that even mean? Is he dead?
If his brain is dead, then Grant will not recover. So in fact, in essence, yes, he is dead. You're welcome to stay here and we can make some tea or coffee. Otherwise, we will call you once we've completed the tests. Do you have any further questions at the moment?
No.
Sandra, Terry, Dr. Forster and Dr. Short have examined Grant and I'll get them to explain what they have been doing and what they have found. Then we'll have a chat about what this means.
Hello again, Sandra, Terry. So Dr. Short and I have both done the Brainstem Death tests now, and I'm sorry to say that Grant is brain dead. So the brainstem is the part of the brain that controls our basic functions such as breathing or heart beating, blood pressure. The damage done to Grant's brain means that he would not be able to breathe for himself. If we turn the ventilator off, then Grant will not be able to breathe anymore.
I'm sure you have some questions.
How did this happen?
Terry, the swelling on his brain that Grant developed is one of the possible risks or side effects of handling in an operation. It happens. It is not anybody's fault. Sandra will be able to tell you this. I know she and Grant did a lot of research before this operation. It is more important though to talk about what to do now. Sandra, do you have any idea of Grant's wishes in a situation like this? Had he and you ever discussed organ donation?
Is there any chance of a change? I mean, if he was to stay like this, where would he be looked after? A nursing home?
No, Sandra, I'm very sorry. There is no chance of a change. Grant will not recover. I'm very sorry. We'd like to give you a little time as a family to discuss what you would like to do now. We can arrange for the transplant coordinator to come and talk to you. If you like, we can arrange for the chaplain to come. You need to consider whether Grant would wish to donate his organs and whether you're willing for this to happen. Or whether we remove the ventilator and allow nature to take its course when you've had the chance to say goodbye. We'll leave you to think on that and come back afterwards.
So in this second version of talking to Sandra and her family, the setting was set in a secure, as in unlikely to be interrupted, quiet room with more comfortable chairs than the first setting. Sandra's understanding of the situation was gauged a little when asking her what she understood. Could have been done better, I think, in this instance. That was something that could have been improved upon. The imparting of knowledge to lead up to the sharing of bad news was done in small chunks and was done free of jargon. I think that was done well. Sarah and her sister and her brother did display different levels of different sorts of emotions, and these were supported, shall we say. Their emotions were recognised and some levels of support were given by the nurse. That too could have been a little stronger perhaps, but I do feel summing up what was occurring for her husband was done fairly well by the doctors, and moving on to where to from here with respect to decision needs to be made about do we continue, and if not, perhaps we could move on to donation of organs, well, as a next step was moved on to quite well here. So in summary, sharing bad news is indeed a challenge, both for the recipient and the person breaking the news, sharing the news. If it's guided by the principles of therapeutic nursing and some sort of framework like the 6 steps protocol, it can be done well. It is a skill. If practiced and followed well, it can be an art, I think. But as I've said several times, if we do it badly, the family or the patients may never forgive us If we do it well, though, they may never forget us.